So thank you so much for coming to this session. I'm sure the meeting thus far is going great, kind of winding down. Today, this session is going to be about healthcare coverage inequities in children with special healthcare needs. My name is Letitia Manning. I work for the Maternal and Child Health Bureau in the Division of Services for Children with Special Healthcare Needs. And at the Division of Services for Children with Special Healthcare Needs, I serve as a project officer for the Catalyst Center. So it's absolutely my pleasure to introduce our next two speakers. We have Dr. Sally Bachman. She's at the Center for Innovation and Social Work and serves as the principal investigator for the Catalyst Center. And we also have Ms. Julia Katner, who also works for the Center for Innovation and Social Work and Health and is a research assistant for the Catalyst Center. And I also wanted to note that Meg Camo is here. She also works for the Catalyst Center. She's not presenting, but she's sending moral support. That's why she had to sit so close to the front here. So before I let the experts really get up here to talk about some of the great work that they're doing around inequities, I wanted to provide a couple of definitions and some demographics about the population of children with special health care needs so that we're all on the same page before they begin. In MCHB, we define children with special health care needs as children who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that required by children generally. Now, yes, this is a very broad definition, but in understanding this definition, it is important to acknowledge that due to the various and complex health needs of the population, there's no easy solution for finding and providing not just health insurance, but adequate health insurance. Although many families of CSHCN have some type of health insurance, it is oftentimes not sufficient or results in tremendous financial hardship for the family. So when we think about inequities that are already prevalent, looking at social determinants of health for many different populations in the US, you can only imagine how those inequities are amplified for CSHCN that live in these particular communities that are already at a disadvantage due to various disparities. MCHB, part of the mission is to assure access to care for CSHCN. And so MCHB developed 6 critical core outcomes to help achieve appropriate community-based systems of services. Many of you might be familiar with these 6 core outcomes, so I'm just gonna go through them pretty quickly. The components of the system are family professional partnership at all levels of decision-making, access to comprehensive health and related services through a medical home, early and continuous screening, evaluation so that children can receive timely diagnosis and timely intervention, organization of community services so that families can use them easily. We also use the term ease of use, as well as successful transition to all aspects of adult health care, work, and independence. And lastly, adequate public and or private financing of needed services. And that's the one that we're really gonna focus in on today. There is a similar national performance measure, National Performance Measure 15 for Title V, which is around the percent of children ages 0 through 17 who are adequately insured. So how many children have special health care needs in the US? Based on the 2016 National Survey of Children's Health, children with special health care needs account for about 19.4% of all US children under the age of 18. Now that might not seem like a large percentage, but it equates to roughly 14.2 million children. So that's a lot of children. And many of these children have some of the highest level of medical complexity, about 320,000 to 560,000, and they account for 15 to 33% of healthcare spending for all children, which is about $50 to $110 billion annually. So now I'm going to jump over into some of the demographics for this population. And I'm going to be referring to the National Survey for Children's Health, the 2016 survey, but I'm also going to refer back to the 2009-2010 National Survey for Children with Special Healthcare Needs. So based upon the current survey, this is a chart on the demographics, the race ethnicity demographics. And according to this data, 24.6% of children identified to have a special healthcare need were Black, 19.6% were white, and 17.6% were Hispanic. And there's also a pretty large percentage that identified as other, which is 16.9%. And before I continue on with some of the other slides, I wanted to mention an article that was written in collaboration, in partnership between MCHB and the Catalyst Center around assuring adequate health insurance for children with special health care needs, progress from 2001 to 2009 and 2010. And in this article, they looked at bivariate and multivariable analysis to assess factors associated with adequate insurance. And in this article, they discuss how non-white children tend to fare better regarding adequate insurance in comparison to their, I'm sorry, I reversed that. White children tended to fare better than their non-white counterparts when it came to insurance and to, for adequate insurance. This is a slide about parental nativity. Out of the 14.2 million children with a special health care need, 13.8% have a parent born outside of the US, and 26.5% live with caregivers other than their parents. So we know that language is an important component around health inequities as well. And Latinos, children with special health care needs living tend to fare worse regarding adequate insurance. And immigrant populations also may experience various inequities related to adequate insurance. Question?
Can you go back?
Oh,
to the prior slide?
Sure. I was asked to go back to the prior slide. Did I go back? No?
There you
Is this, okay, all right.
So for children born in the U.S. who live with caregivers other than their parents, does that reflect a higher proportion of children with special health care needs in foster care?
Can you repeat that question?
Okay, if my voice didn't carry enough the first time. I'm curious about the middle pair of bars, and I wonder if to what extent the proportion of children with special health care needs born in the U.S. but living with caregivers other than their parents somehow reflects a higher rate of engagement in foster care.
So it is very possible that that could be the case, but this data just came out, and folks are still doing some analysis around it. So I can't say yes or no to that, but that might be a really good hypothesis at this point. I'm not sure if any of my colleagues have anything additional to add to that question, but thank you. That's a great question. And this slide is from the survey, the National Survey for Children with Special Health Care Needs that was done back in 2009, 2010. And when you pull out the specific core outcome around having adequate private and or public insurance, white non-Hispanic families of CSHCN were more likely to report having consistent and adequate private and or public insurance to pay for the services they need. And I really want to emphasize that the data on this chart is for consistent and adequate insurance, and that includes 5 different components. Currently insured, consistently insured over the past 12 months, usually or always can see needed providers, covers needed benefits, and out-of-pocket costs. So those are the 5 things that they're looking at in regards to consistency and adequacy of insurance. And so now it is my pleasure to turn it over to Sally to take a deeper dive.
So I'm not very good at standing at the podium. So, can you hear me? Are you? So I'm going to walk around a little bit because I get nudgy standing up there. So today, and today only, I'm the face of the Catalyst Center. How many of you have called the Catalyst Center at any time? So I want to say thank you for calling us. We love it when you do, because not only do we get interesting puzzles to help you solve, we also learn from you. Every time you call us, it gives us an opportunity to learn more about what's going on in your states, the Title V and Medicaid and financing matters that you're thinking about. So call us often, because we like to hear from you. I want to also say that actually I'm like the person behind the curtain. The real people who do the work are Meg Kamom, my esteemed and brilliant colleague, and we've been working together for 12 years, maybe more, so everything I know I learned from Meg. And our new research assistant, Julia Kantner, who put quite a bit of thought and conceptual energy into this presentation, so you'll hear from her. But the real captain of the ship, literally and figuratively, is Letitia, who we just couldn't be more lucky to have the project officer that we do, who allows us to think with her about important problems that we can help resolve. So the Catalyst Center, as some of you know, we focus on financing services and supports for children with special health care needs. We provide technical assistance about everything from policy, practice, implementation, the tiniest detail about the provision of whether or not you can bill Medicaid for that. We do policy research. We try to create useful resources. It's very important to us that our resources are valuable to you. You can find them on our website. And we connect folks together who are interested in working on financing problems. So it's our great joy and passion to work with you to try to help you address these important issues. One of the areas of exploration for us, because we're continually trying to grow in what we do, we're trying to make ourselves better for you, is we decided, with support from our project officer, that we really wanted to start to tackle the question of inequities. So we could see in the work that we're doing that the system of financing health services for kids with special health care needs is not equitable. And it's not equitable along a number of dimensions, starting from household income, race, ethnicity, functional status, age, household language, immigration status, and many other dimensions. And so, given that we have this robust knowledge base about kind of the particulars about healthcare financing works, we thought that it was our obligation to try to work on this question of inequities. And one of the first things that we have done is we have created a tutorial, which you can find on our website, about, it's a worksheet, it's a series of educational components, and then there are worksheets to help you think about inequities in your state. Now, we have developed much of the tutorial using data from the 2009-2010 survey of children with special health care needs. So far, we haven't been able to replicate those data for the new survey. So for the time being, you're going to find that the survey data that are reflected in this tutorial are from the last National Survey of Children with Special Health Care Needs. And we'll do our best to keep this tutorial updated. We take you to the survey data to help you do some worksheets in your state to sort of think about what's going on in your state. But today, I want to talk with you about some sort of experimental work that we've been doing. We did a series of interviews with staff from the offices of minority health in each state. Now, some of you have probably participated in a phone call interview with someone from the Catalyst Center about the Title V program in your state or the Medicaid program in your state. So I see a couple of heads nodding. So we decided to replicate that methodology with offices of minority health. We thought that it would be useful to sort of try to get a lay of the land about how is this conceptualized at a state level. And then we also decided to do some focus groups with parents of children with special healthcare needs who are from the Somali community in Boston. We decided to start with an achievable goal, and we know from other work that we've done that there's a relatively large Somali community in Boston, and I'll explain a little bit more about how we became engaged with that group. But I want to start by talking about some overall work that we have done both at the larger center, where the Catalyst Center is located, and within the Catalyst Center specifically. So I am definitely not a member of the Somali community. I am a white, middle-aged, middle-class professor who does not have a child with special health care needs. So we decided that in order for us to approach this process with humility and with an appreciation of kind of our place in this landscape, we have done a fair amount of work in our organization around cultural humility. So we've had consultants. The Catalyst Center has helped us support this work, but we've done quite a bit of work inside our organization trying to learn more about how we think about ourselves when we're trying to focus on inequities that may not be a component specifically in our own lives. We decided that, particularly for the work that we were doing with the Somali community, that we would collaborate with a person, and we'll talk more about this, that we're calling a cultural broker, someone who can help us think about the process of what we're doing, not just the outcome of what we're doing. And as a researcher, that was a very important piece for me because I can jump right to the data and implications faster than anybody can. And so, slowing that process down and thinking about it more as a group was an important part of what we're doing here. So I want to, in absentia, thank the participants in our focus groups. You'll see more about that as I go along. So just a couple of points about our Office of Minority Health Interviews. So what we did is we gathered data from state officials who work specifically in offices of minority health. And we did sort of a broad-ranging interview. What kinds of initiatives do you have? What are you doing? Does any of the work that you're doing apply specifically to children with special health care needs? And we tried to contact all 50 states. This is using the same methodology that we have used for interviewing Title V and Medicaid representatives and family leaders. And we tried to keep the pattern parallel so that we could think about these results in comparison to the information that some of you have given us. So it was interesting. We only got responses from 12 states. And according to the methodology that we use, and for those of you who've done an interview with us, you know that we come back again and again and again to try to get you to talk to us. So I see even more heads nodding now. So we're persistent, and we are persistent to the point where we look at each other and we say, okay, are we getting annoying? And when we decide that we're getting annoying, we stop. So we ended up with 12 states. These were phone interviews. So just some things that we learned that we thought would be beneficial to share with you in your role as state policy, practice, family leaders. There are a variety of structures for these offices of mental health. Big, small, different levels of organization. And how they're structured affects what they do, who they collaborate with, who their conversations are with. We found that very few of these offices are thinking about children with special health care needs. Very few also address coverage and financing issues. So one of the things that we try to do in our work is to find potential partnerships for Title V and family leaders. So we do think that these offices of minority health are a potential collaborator if you're thinking about trying to address inequities in your state. We found that there is training going on, that the offices of minority health are doing training internally, externally. We found that they are reviewing equity and racial justice policies. So there's work going on there that we think could be beneficial to you as you're trying to think about inequities in your own state. So let me just stop there for a second and see if you have any specific questions about that. Yes, hi.
Would Office of Minority Health be comparable to Office for Immigrants and Refugees, or is that a separate?
So the question is, would an Office of Minority Health be similar to an Office for Immigrants and Refugees? I think not. For a variety of reasons, including immigration policy and services for people who are refugees. Also, offices of minority health are more broadly conceptualized, I would say. Julia, do you want to weigh in on that? Okay. Good question, though. Other questions? Okay. So again, framing the work that we have done around some focus groups with parents of children who have special healthcare needs who are members of the Somali community, we have found very little work on financing inequities for children with special healthcare needs. And so this, as I mentioned previously, is becoming an area of focus for us. We want to be able to think about this along all the dimensions. We think that it's very important to understand cultural implications of having a child with special healthcare needs, as well as inequities, structural inequities, and other inequities that are in our system with respect to race, ethnicity, class, and so on. So we decided that we would just put a toe in the water and begin to explore this. We decided to sort of stay close to home. We originally thought about conducting focus groups in other states, and it wasn't going very well. And so we thought that we had sort of set our goals a little too high. So we backed up and we thought, well, let's just do something closer to home and try to teach ourselves more about what's going on. So we have learned, as I mentioned, the process is just as important as outcome. And we have been working with a person who we think of as a cultural broker. She is a member of the Somali community in Boston. So here's what we tried to do with these focus groups. We tried to hear from Somali parents and caregivers about barriers their family may have faced in getting and maintaining health insurance or paying for care. We wanted to hear about resources or specific services they may have received, as well as barriers that they may face as they are working to access and pay for services for their child with special health care needs. So these are very exploratory questions. We tried not to go into it with too many sort of testable hypotheses. So we recruited two cultural brokers. These are women who are representatives of the Somali community who are very well respected in the community. One works at Children's Hospital, so has exposure to children with special health care needs. And then as a result of that connection, or I should say simultaneously with that connection, Naima, who was really our essential partner in terms of helping us with the focus group guide. So we asked her to critique what we had written in the focus group guide and try to improve the quality of the questions. She helped us with translation of the materials. She developed a recruitment plan for us, which we worked on collaboratively. She convened the focus groups, advised us on interpreting the results, did translation of the results, and ultimately approved this presentation that we're giving today. So she's been involved with us at every step of the way. We've conducted 4 focus groups. 2 were conducted in mid-July at a local mosque, and then 2 were conducted in December. And we did this kind of incrementally to again, in sort of teaching ourselves as we went along. So just yeah. Yes. The question is, were either of our cultural brokers parents of children with special health care needs? No. Right? I'm pretty sure no.
No.
Yeah.
And I would say that there was definitely some bidirectional learning as far as how we define children with special health care needs and kind of what we're looking to understand. And then we learned a lot about the Somali community from her, so there was definitely a lot of learning in both directions there.
Other questions? I appreciate the questions. Yes.
Can you describe how you identify the cultural brokers? How did you make contact with the community?
Yes. So the question is, how did we identify the cultural brokers? So as I alluded to, we had a lot of false starts with this project. We had, so for example, we had to make sure that we were working under the Institutional Review Board, Protection of Human Subjects regulations. And so our first start with trying to do this focus group was actually with a family leader organization. But our requirement that we have IRB approval, which we felt was very important in terms of the ethical protection of human subjects, that we were unable to make that work. Then we went to a nonprofit organization, and we ran into some of a nonprofit organization that works actually with immigrant and refugee populations. And we were trying to work with that organization, having moved from a family leader organization to a nonprofit organization that specifically works with this population. We ran into a similar IRB problem. And so we were just about to throw our hands in the air and sort of say, oh, maybe this isn't meant to happen, because we felt that we were making enemies along the way, which was really the exact opposite of what we were trying to accomplish. When a person who worked at this nonprofit, Naima, said, well, I'd be willing to do it with you if you sort of hire me as an individual worker. And so that's how we got to her. So reaching out into the community was, I guess, the short answer. Meg.
I'd just like to add, I think Sally alluded to this, but I just want to bring it out a little bit more. The challenges that we faced with the family-led organization and the community-based organization were related to administrative burden in the IRB, not a difference in philosophical outlook or framework.
Very important, thank you. Because we had to comply with the regulations, but the university required certain administrative this and that from the organizations, and it was, as Mag suggested, onerous for them to do so. I thank you for saying that. Other questions? So some lessons that we learned just before we kind of dig into some of the results. We found that this cultural broker was essential. As a person who, as Julia said, helped facilitate sort of bi-directional communication and thinking about what it is that we're trying to do, what's the best way to go about doing this. We really enjoyed it. For those of you who've worked with the Catalyst Center, we really like bridging. We like bridging from an academic position to people who are doing real work in the community, and so that value is very important here. This was a long process, and we had a couple of failed starts, and we learned as we went along, but it wasn't, it wasn't a speedy process, and it's important to allow time for relationship building, to develop communication, trust, understanding, and in keeping with our own work around trying to understand cultural variation and cultural humility. So at this point, I'd like to turn this over to my colleague Julia, who's going to give you a little bit more information about the results, and we'll have some time for more questions as we go along.
Thank you. Unlike Sally, I'm going to firm myself safely behind this podium. So I just want to tell you a little bit about the demographics of our focus group. So we had 36 participants total. That was broken up over about 4 focus groups. All of the mothers were mothers of at least one child with special health care needs. The majority were born in Somalia, and the majority had been in the U.S. for over 10 years. Just a few had been in the U.S. for less than 1 year or 1 to 5 years. The majority also spoke Somali, with a smaller percentage speaking the dialect of Bantu, and none reporting speaking English at home. So this is just a little graph of the education levels reported by the participants, and I should say this information was collected in a self-reported survey at the beginning of the focus groups, just to give us a little bit of information about whom we were speaking with. So there's a range from no schooling to having received a graduate degree, the majority around receiving around an 8th grade or less level. And we also asked about how participants tend to communicate with their medical providers, and we see about half communicating through an interpreter, and then a few less communicating and speaking English with their doctor, and then a portion also using their child as their interpreter in their medical appointments. And so there was also a wide range of the size of families. It ranged from 1 child to 11 children, with the mode being 4 children. We also asked in the survey if parents would check off any diagnoses their children received from a medical professional. And so we saw about 36% of mothers had at least 1 child in the family with a behavioral or conduct-related diagnosis, so that could look like oppositional defiance disorder or conduct disorder. And about 47% of the diagnoses would fall under a behavioral diagnosis. The way the survey was set up, we weren't able to find out if it was dual diagnoses or children with multiple diagnoses, or if it was multiple children with special health care needs. We simply had a list of the numbers and types of diagnoses. So 33% of mothers had at least 1 child living with asthma, and then a percentage living with diabetes, and 14% reported having a child with an intellectual disability. And the diagnoses ranged from those which we had listed to substance use disorder, genetic and congenital conditions. So some themes of the research from the qualitative data is what we'll discuss next, and then we'll also go through some example quotes that just kind of exemplify each theme. So the first theme was linguistic barriers, which I don't think is a surprise to anyone, but there are a lot of ways we can break down how linguistic barriers affect both access to care and coverage and financing. So the first thing that came up with was an issue with language access, so whether that's having a Somali translator on site or having materials translated. That was a big issue that came up for mothers. For example, if your information about referrals that you need to fill out is in English, you might not be able to fill out your referral form to see a specialist. They also had concerns about interpreters around differing dialects, so there might not be a distinction around Somali and Somali Bantu, and so they might have an interpreter that the doctor thinks is interpreting correctly, and there could be large language differences on what they're actually interpreting. Additionally, there was some discussion around educational development around interpreters, so to make sure that the medical literacy levels are high enough so that there's not a misinterpretation between the doctor and the interpreter, and then the interpreter and the family, which could cause concerns around the care plan. And then lastly, there's a need for culturally sensitive communication around treatment and the treatment plan. That way everyone's on the same page with next steps and what the family can expect. One quote from a participant was, "All of this is because of the language. They send us a letter and we don't know how to read it and don't understand it." So you can imagine what a breakdown in communication like that would do to getting treatment for a child. Another theme was a desire for more benefits counseling and education around services. So when asked with thoughts or questions or issues with CHIP, for example, only one participant knew what CHIP meant. And so if you're trying to understand what services you can get, what your coverage is for, if you don't understand and haven't been taught what your insurance is, that can create some barriers for communication. So many of the participants qualified for insurance, whether through refugee status or income, but some did not know that they were able to qualify. For example, they were told, I can't qualify for Mass Health or Medicaid because someone in my family is working. And even for those that are insured, concerns remain. As Letitia shared, there's a difference between adequate coverage and coverage in general. So there was a lot of concern about adequate coverage, insurance churn and consistent coverage, and then confusion around what services or specialists they were eligible for, and how to complete referrals. So there were a lot of quotes around this. One was, "When insurance expires, we apply, but it's always a problem. It comes late, and if a child is sick, then you get billed and you have to fight it." To my 2 children, one has diabetes and the other has a heart condition. And sometimes I cannot get them to be seen because I did not do the referral paperwork for the specialist because I do not understand how to do it. So you can see that there's a definite need for some counseling and benefits education. The next theme was discussing experiences of racism and unfair treatment by providers. And this can clearly lead to a lack of trust in providers. Additionally, we saw that some women would change their provider because they were receiving unfair treatment, and this can create poor health outcomes and dangerous health outcomes because it can lead to inconsistent care, duplicate care, gaps in care, so that was a concern as well. For example, we are standing in line waiting to be checked in, and the person behind us, who is white, is asked, "May I help you?" You ignore us and treat us like we don't exist. Our children are treated differently, one way or another. Somalis got mistreated by providers because they are different and they assume they don't know things or are not citizens, or because they don't have a good interpreter. So I think that quote sums up a few of the different inequalities and burdens that this community is bearing in trying to access health care. So another theme was the adversarial ally, and I'll take a moment to define that. This was actually a theme that was named for us by one of our consultants, and she shared an article with us by Kelly and Chapman that's discussing the relationship in many systems of care where the provider is given the power and those seeking support are without power. And so while they simultaneously need a service that is vital to help them, it can also be oppressive at the same time, and some of the tensions that creates in accessing care. So they named feelings of distrust, confusion, and worry, and there were some abundant stories of negative experiences in the community. Additionally, we heard a few things about limited recourse due to faith beliefs. So for some women, they believe that it's not in a part of their faith to sue or to pursue lawsuits, and so it limits their venues for recourse and amplifies the power dynamic when one of the avenues for justice, which is the legal system, is something they feel that they cannot access. The doctor told me that he has the power to take away my child. I brought this child from refugee camps. I carried him from hospital to hospital, from Somalia to Kenya to Uganda to the US. I did this all to get him medical care. This man told me I did not know what I was doing. He accused me of making my child sick. He told me I failed in my duty as a mother by not giving my son the medication. I think this quote reflects all too clearly some of the power dynamics and the real effects on a family can have in a family when they're seeking care. Another theme we saw was the stigma of illness and fear for seeking help, and we can see how this would be directly related to experiences of racism and adversarial allies, and so it could be seen as a natural progression from the two slides we just discussed. So some themes under this were fear of caseworkers reporting on the family, fear of stigma from help-seeking behaviors, but there was a large range of feelings amongst the participants regarding this theme. Some felt that there needs to be more of an inclusion in caseworkers and are beginning to change these themes, while others were really still held on to the experiences they had that made them feel unsafe. My husband's last words before he passed was, "Case managers are the worst. Don't let them into your home. When you allow people from outside your culture into your home, they can cause you more problems." My case manager told me, "You have a lot of things you can access. For example, a chair to support your son in the shower." The case manager will pretend to help you, but they come into your house and report your house is dirty. And you can see that being connected to the other quote where they were talking about a doctor threatening to take away their son. There's a real fear of, what will this do to my family? And yet I need to be able to get my child the care they need to be healthy. And another theme was a need for more community support. So one of the questions was around what services have really worked for you, and those who experienced community support had some better experiences, and there was a call for more of that. So the community identified it as a possible solution to many of the barriers discussed to help navigating the systems and benefit counseling, as well as addressing some of the stigma and reducing fear. We need more community leaders and advocates to help us with health needs. Their job is to help with these things, to do outreach and tell people what they need. We need more community classes to explain health and how we can understand the system better and help our children. So we can see how many of these themes tie to the core outcomes for maternal and child health, wanting access to community care, wanting parents and families to be part of decision making. So there's a lot of progress that we can examine here. So in summary, one of the great things about the focus group was that it served a dual role, research and understanding on our end, as well as some education in the community. And our cultural brokers reported back that the focus groups were really appreciated for the cross-education and community, and some women actually went to case managers afterwards to help get insurance because they then learned that they were able to get Mass Health and Medicaid. So there were some real tangible effects just directly after the focus group already. And we saw that participants who had been in the U.S. for less than 5 years faced similar challenges to those who had been in the U.S. for 10 years, so we can really see some systems issues within accessing care. And then we see that we're working at the intersection of multiple themes: children with special health care needs, the role of family, race, religion, fear, stigma, and more, and recognizing that many of these themes reflect the challenges of many families with children with special health care needs of all demographics, and we see there's the intersecting additional challenges for coverage and care, which many in the Somali community face. And I'll hand it over to Sally again to talk about implications and next steps.
So I'm just going to, a couple more slides, and then we'll have some time for questions and answers. So thank you, Julia. Great work. We were trying to think about implications that would be helpful for you based on this work that we have done. First, trust building is essential. It became clear that having someone who was a cultural broker, a member of the community, was essential for us to be able to do this collaborative work and conduct the focus groups. It's very important to avoid becoming an adversarial ally, which I think is potentially a phrase that many parents of children with special health care needs can relate to. You're in a struggle with a medical system that has what you need for your child, and the power dynamics are relevant for this adversarial yet allied relationship. We need more workforce development. You could see that there was just a lot of opportunities for education and training for family leaders, for providers, for others in the system. And it's important to think about intersectionality. So trying to think about the multiple dimensions that are intersecting in the lives of the women who told their stories to us. So it's a woman who is the women were primarily members of the Muslim faith. They were all from Somalia. They all had children with special health care needs. So this intersectionality needs to be considered as a total problem to be addressed on these multiple dimensions. As Julia said, there was education that was happening within the focus groups, bidirectional, certainly at an organizational level. So we learned, and the women learned, but they also were teaching each other. And those of you who are family leaders already know this, that that's an important role for family leaders. But there's a big need for more community education and partnerships, and this is something that the Catalyst Center has been promoting for years now, trying to find partners to move forward in terms of these financing issues. Implications specifically for Title V, more collaborations between families and professionals. Obviously, Title V leaders are already trying to do that, but thinking about these collaborations with this intersectionality lens and trying to do the extra work that's really needed to create trust with specific subgroups of families with children with special health care needs. And we have in our tutorial examples of partnerships, and we're in the process of adding some additional information there, for example, about offices of minority health. But we want to hear from you. Like, who are you partnering with? Help us, teach us too about the partnerships that you're developing as Title V and family leaders. Going back to the tutorial, we encourage you to take a look at it and call us with any questions. We'd be delighted to talk with you about it and to hear more about how you can use this in your state or suggestions for improvements, how we can make this thing better. So for next steps, this is the first time we've spoken publicly about these focus groups, so we want to do some more dissemination. We continually are looking for partnerships to develop best practice models, and if you want to work on something like this in your state, give us a call and we can talk about whether or not it would be feasible. We want to replicate this process with other subgroups of families of children with special health care needs, and create as many resources as we can. We're very committed to doing that at the Catalyst Center so that we make information easily available to you, and with luck it will be relevant and practical to help you with the issues that you're working on in your state. Thank you. So from me and Julia and Meg, and very importantly our project officer Letitia, and whoops. I wanted to go back to sorry. Thanks, Julia. Oh, actually, I can probably do it. So we welcome questions or discussion, constructive criticisms. We're pretty robust, so. Anything? Yes, hi. Mm-hmm.
In helping families obtain and get the services and the education that they need.
Mm-hmm. So the question is about how to develop health literacy materials that will be really useful to families.
And health literate environments that help empower families. I think it's related to that trust.
Yes.
But also so that families can feel that they can ask those questions because they're in an environment that supports asking questions and things like that.
So I think creating safety for families is very important, and trust building. And I want to turn also to Meg and Julia to add to what I'm saying. But having a representative of the community who was trusted and knowledgeable, I think, was essential in creating this safe space for families to say the things that they said. We sort of had to stop reading the results at some points because it's very painful to see the experiences that the families have had. So engaging the community in a true partnership, I think, is the way to go. Also, allowing enough time. I can't emphasize that because all of us are on, budgetary cycles and deadlines and process that you have to go through. But allowing enough time for the process to work, I think, is very important. We have also done quite a bit of work at the Catalyst Center around plain language or various iterations of trying to make complex topics accessible for individuals of all, reading levels or levels of comprehension. And, if I try to sit down with my dad to explain his health insurance to him, he doesn't want to hear it. So it's not an issue having to do with particular subpopulations. The material that we're talking about is really complicated. And so we've spent a lot of time thinking about that. Working in partnership, I think, is very important. Engaging members of the community, as we did, for example, in the focus group, we had what I would consider to be pretty straightforward focus group questions that were actually offensive. And I wouldn't have known that without the engagement of the community. Do you want to say anything else about plain language stuff?
Not necessarily directly related to plain language, but I did want to just share a thought that I had while you were talking about intersectionality and trust, and Suzanne's question about were any of these cultural brokers that you worked with parents of kids with special health care needs. I think our thinking around that was that this is a developmental progression, and we needed to develop some trust, and we needed to develop some street cred with the Somali community as a whole first before we could take that leap and try to elicit input and collaboration and partnership from the special needs community. I know for myself personally, as a parent of a child with special health care needs, reading the results of these focus groups, a lot of it felt really familiar. Yeah, wow, okay, that happens to every family member that I've ever talked to and myself personally. There were other things, though, that just blew my mind that were completely outside my own personal experience. So I think that might be the next step in our developmental trajectory in doing these kinds of focus groups, is to develop street cred in the community as a whole and then be able to reach out to families of children with special health care needs, because there are things that are very specific and targeted that we can elicit from them. But you have to take your time in doing that, and really, as Sally mentioned, having the confidence and the trust of our project officer and being able to take that time to build that trust was really incredibly important.
And I just want to add one thing that was mentioned by Sally earlier on about the work that that the Catalyst Center has done around cultural humility amongst themselves. I think in engaging with any of this work, it's really important to acknowledge the biases and the perceptions and the things that we have, and breaking down some of those walls and stereotypes that we have in our minds can also help facilitate an environment where folks that may be a little hesitant, or they have a perception of how they think we'll view them. It does something. Your approach changes, your thought process changes, and it allows for them to feel safe within that space. So I think that's an important component as well.
Did you want to add anything, Julia? Did that answer your question? Okay, thanks. Other questions? Somebody else had there. Hi.
Hi. And I know this is probably out of the purview, but as I'm hearing the quotes from the families, I kind of want to strangle a couple of doctors and some case managers, because that's the stuff we do here as parents. So is there any plan down the road to look at some of that training around some cultural humility? Because they really kind of
Yeah. So the question is, around training for people in the provider system. So those particular, having done, like Meg and I did a whole project on financing care coordination. So then to read these quotes that you don't ever let a case manager in your house, and the importance of care coordination for families of children with special health care needs, that was just really painful to see. So I think there are multiple levels. One level certainly is more training and education, and I think Title V programs and family leaders have a role to play in this in terms of sponsoring those trainings, doing the work of making it easy, I'm sorry to say that, but easy, efficient for a physician to get to that training. So I think Title V can do some of that. I also, something that we've been thinking about is workforce development from the communities that you're trying to reach. So if you have a large, for example, population of people who are Somali refugees, so one of the people who worked with us on this project actually works at Children's Hospital, and she is an MSW. So training and developing family leaders, let's say, or other members of the workforce as representatives of those populations and people who can help to promote trust, I think is the way to go. I think family leadership organizations have a really important role to play here, both in terms of making sure that that the women who were in our focus group know that they are part of that community of family leaders, I think is something that could also be useful. Again, I want to say I think it's slow work, slow and intentional work, which is hard because I will speak for myself. Over the year that it took us to do this, year plus that it took us to do this, there were a few times when I'm thinking about, the PI of this project, am I making the best use of these precious resources that we've been given to do financing of healthcare for children with special healthcare needs? I second guessed it a number of times. So it requires sticking to it, I guess. Others? Hi.
I was gonna, it's great work in Minnesota. We've been
Yes. Mm-hmm.
the best thing you could do is actually have a presenter that was Somali.
Yes. Yeah.
Along with you.
Yes. Yes.
That says more than I think anything, and actually would change the environment for the actual doctors.
Yes. Thank you. So the suggestion was, as a person from Minnesota that also has a large Somali community, it would strengthen our presentation to have a member of the community with us. We absolutely agree with that. We did, Julia actually has been the person Julia has an MSW and is in our MPH program, so we rely on her for her clinical and other skills. So Julia's been working closely with the cultural brokers and did work with them on the content of the presentation. But going forward, I think your suggestion is really the way to go, to have a member of the community here with us or giving the presentation.
I think in changing anything, we actually hired a staff member.
Yeah.
That is not only the liaison, but you end up having cultural dynamics or community dynamics.
Yes.
That go beyond messaging and that trust.
Yes.
That is more than I think you can't even imagine.
Yes.
Between the medical and non-medical.
Right. And sort of building this environment that we're talking about of trust and of really moving the whole bar forward. Yes, that's a great suggestion. Yeah. Yes.
Into ongoing messaging and the children and youth with special health needs is trying to understand that and
Yes. Yeah. Thank you. Minnesota was on our list of states but we decided to back up and try to work in our own neighborhood, because we were kind of feeling a little discouraged at our false starts. But I appreciate your suggestions very much.
Lots of focus groups and policy groups and.
Yeah, good. Other? Hi.
So regarding the offices of minority health that you were in touch with, so it came up that, there was little, interaction or understanding of children with special health needs. Any sense of an openness to that or, a way forward?
I definitely think that it's worth a try in terms of communicating with your Office of Minority Health. The staffing patterns vary, and the amount of labor that they have available, I think, varies from state to state, but I absolutely think it's worth a try. And it's also possible that some of these suggestions, so for example, the suggestion from Minnesota, some of these things would come to you more easily, and you wouldn't have to go through as much learning, potentially. So I definitely think it's worth a try. Good. Other questions? No? Oh. I got the hook. So thank you, everyone, and thank you, Meg and Julia and Nikki.